Now, whatever clinical area you work on, it's important to be on the lookout for hemorrhage. And what we're going to do in this section is think about observations that we might make in people with diseases that can indicate that hemorrhage is going on, and maybe a little bit about what that means. And the first one I want to mention is hemoptysis. Mop, cough, hemoptysis. Hemoptysis is the coughing up of blood. So why might people cough up blood in their sputum? Well, it might be tuberculosis in the lung, pulmonary tuberculosis, damaging blood vessels, letting blood into the mucus where it's subsequently coughed up. Or it could be an indicator of bronchogenic carcinoma, because carcinomas can erode through blood vessels, again causing hemorrhage. Even in someone with chronic obstructive pulmonary disease, COPD, where the patient has bronchitis particularly, you might get small blood flecks in the sputum as a result of the COPD. It's possible. And there's another fairly classic clinical observation. People with pneumonia caused by the pneumococcus bacteria, they can cough up rust-coloured sputum. Now, it won't be at the time of the acute infection, it might be a few days afterwards, but they can get rust-coloured sputum. And that's pretty diagnostic of pneumococcus, really. Because what happens is that you get some blood cells in the capillaries, some blood cells in the alveoli rather, from the capillaries. So the capillaries are around about the alveoli. You can get leaking of some blood from these capillaries into the alveoli, but they get well mixed up with all the other exudates and things that consolidate in the alveoli. And then by the time it gets up, it's being converted into a rust-coloured sputum. I think it's diagnostic. I can't think of any other bacterial infection that will give it, indicating pneumonia. So that's hemoptysis, coughing up of blood. And it can occur in trauma as well, of course. It will obviously occur in trauma. The next observation is hematuria. This means blood in the urine. And this can indicate disease in any part of the urinary tract. There could be a tumour in the kidney. There could be renal calculi in the ureters. There could be severe infection or calculi in the bladder. Or there could be severe infection in the urethra. Basically anything in the urinary tract that goes wrong enough to make bleeding into the urine, well, obviously any of these things are going to cause hematuria. But it's important to realise that hematuria can be frank or hidden. Now, frank, in fact this is true with all forms of hemorrhage, frank means it's obvious, you can see the blood. But it can also be occult, which is hidden. So sometimes we can see blood in urine, which is fine. Other times we need to test for it with our dipsticks, and it will come up positive for blood. And of course, if we're in any doubt, we can send it off to the path lab and get them to confirm the presence of red cells. And of course, blood in urine, as indeed is the case with blood in sputum, is always a pathological finding. It's always abnormal. So anytime you find blood in the urine of a man, that's always abnormal and it should be explained. Anytime you find blood in the urine of a woman, that could be menstrual contamination. That's possible. So it's worth asking at what stage of her cycle she's in. Now, if she's mid-cycle and there's no possibility of menstrual contamination, then that means that is automatically a pathological finding. That blood should not be there. If it's round about the start of the cycle, day 1 to day 7 or 8, when there's the possibility of menstrual contamination, do not assume that that blood is caused by menstrual contamination. What you need to do is retest her again in 2 weeks' time to confirm that there's no blood there when she's mid-cycle. If there's not, fair enough, but if there is, that's a pathological finding. So hematuria, blood in the urine. Hematemesis, hematemesis. Emesis is being sick. Antiemetic drugs prevent sickness. So hematemesis is vomiting up of blood. And again, this can be frank blood, which looks like blood, or if the blood's been in the stomach for a period of time, the blood is altered by digestive processes in the stomach. And this turns it into a coffee ground looking substance. And it is just like coffee grounds. If you ever make percolated coffee, the ground coffee you get after you've made the coffee, that's exactly what this blood looks like. It's coffee grounds vomit. But you can get a mix of these. You can get a mix of frank blood with coffee grounds when the patient vomits. But often a patient will vomit and you won't see frank blood, but you will see these coffee grounds. And we have to know that that means that it's blood. It's altered blood. We call this altered blood. And if you're in any doubt, you test it with your dipsticks and it comes up positive for blood. So the patient might have had dental extractions or injury to the mouth and swallowed a lot of blood. That could cause later vomiting. Or there might be disease of the esophagus. The classic one might be esophageal varices, where there's varicose veins in the esophagus. They can cause torrential bleeding. The blood goes down into the stomach, the patient vomits, and we see the hematosis. Another classic one is peptic or duodenal ulcer, bleeding into the lumen of the duodenum or the stomach. Or of course there could be a tumour, because tumours can also bleed. But as the previous examples, it's always pathological and should always be explained whenever we see blood in the vomit. It's a sign of something gone wrong that we have to explain. Now, melena is the passing of blood in the faeces, but the melena is dark and tarry. So what's happened here is there's been bleeding into the upper gastrointestinal tract, and rather than that blood being vomited out, it's gone on through the gastrointestinal tract and it's come out the other end, and it's dark and tarry, and it's got a characteristic dark and tarry appearance, and it's also got a particularly bad characteristic smell that probably unfortunately you are going to come to recognise if you do much work on medical wards. So melena, indicating bleeding in the upper gastrointestinal tract. But more frank blood can also come out of the rectum as well. So a patient can pass blood in their stools, or there can be blood on the toilet paper, because there's PR bleeding, per-rectal bleeding, sometimes of fairly frank blood. Now, the most common cause of this is hemorrhoids, varicose veins in the rectum, what a lot of people call piles. These can bleed, and actually quite a lot of blood can be lost. But also it could be something more sinister. It could be carcinoma in the colon or carcinoma in the rectum. So again, blood in the stools is abnormal and should be explained. And again here we can look for frank blood, and we can also look for FOB, fecal occult blood. And in fact this is quite a good screening tool for adenomas or adenocarcinomas, polyps or cancers in the colon itself. If we do FOBs times 3, fecal occult bloods on 3 consecutive defecations, from faeces from 3 consecutive defecations, we can look for blood. Now if we find occult blood, hidden blood, as a result of our test that we couldn't see by looking at it, then again that occult blood is a pathological finding and should be explained, and that's a possible indication for colonoscopy to diagnose where that bleeding is coming from. So PR bleeding. Intracranial bleeding is blood into the cranium. The cranium is the vault inside the skull, and there can be intracranial bleeding. Now, this can occur as a result of degenerative processes in arteries within the brain itself. So there can be progressive atheroma of blood vessels in the brain, and the atheroma predisposes to aneurysm formation. Now, an aneurysm is a weakness in the wall of a blood vessel, and it's going to enlarge, and you can get what you call a fusiform aneurysm, an enlarged area. But as the aneurysm gets wider, then it's going to stretch and make the wall of the blood vessel thinner, and that's going to predispose it to hemorrhage. And you can get an intracerebral hemorrhage into the brain. Now, most strokes, most cerebrovascular accidents are thromboembolic. They're caused by thrombus or embolization of a thrombus, occluding the blood supply from an area of the cerebrum. But about 10% of strokes are hemorrhagic, where there's actually rupture of an aneurysm and hemorrhage into the tissue of the brain, causing a hemorrhagic cerebrovascular accident, another pathological form of hemorrhage. And another form is subarachnoid hemorrhage. Now here you've got to remember your anatomy. Remember you've got the dura mater, the arachnoid mater, and underneath that you've got the pia mater. And in the subarachnoid space, between the arachnoid mater and the dura mater, you've got the cerebrospinal fluid. And a subarachnoid hemorrhage will bleed into the subarachnoid space into the cerebrospinal fluid. So if there's blood in the CSF at LP, blood in the cerebrospinal fluid when you perform a lumbar puncture, that is diagnostic of subarachnoid hemorrhage. Bleeding into the cerebrospinal fluid in the subarachnoid space. And this can be caused by disease of the arteries or trauma, but much more commonly, by far the most common cause, is rupture of saccular berryaneurysms. Now these just look like berries. They're saccular aneurysms and they're congenital. Someone is born with them and they can grow and the walls can weaken as life goes on. And they're typically associated with arterial bifurcations in the area of the circle of Willis, at the base of the brain. And these can rupture. And when they do, they're probably going to cause the most appalling thunderclap headache. Patients say that it's the worst pain they've ever experienced in their life. A really sudden thunderclap headache, very often at the back of the head. The patients, of course, are very distressed and they're also likely to be photophobic. They don't like bright lights, but diagnosed with a lumbar puncture. And very often neurosurgeons can clip off these bleeding berryaneurysms and stop the hemorrhage. I want to talk about contusion now. Contusion is just a technical word for a bruise. And typically this occurs because of damage to capillaries. So a contusion just means a bruise. Bruising can be obvious on the surface of the body, or of course there can be internal bruising as well. That's also possible. Now, there's another time that blood can leak into the skin, and this is called purpura. And this gives a purple appearance, so purpura, purple. And what you get is like areas of blood under the skin that deoxygenates and looks dark blue or purple. So purpura, purple areas because of blood in the tissue spaces under the skin. And this can leak out, for example, if someone's got very few platelets in their blood, if they're thrombocytopenic. So quite a serious clinical feature. And there's a subset of that really called a petechial rash. Now a petechial rash is small areas of hemorrhage. And they start off red, but then as the blood deoxygenates, they become dark red. And for the purpura or for the petechial rash, you can check by pressing with a glass on the surface of the skin. For example, this is a test that we use in meningitis, where you can have a petechial hemorrhagic rash as a result of meningococcal septicemia. And if you press on the rash and that rash fades and the skin goes white, that means that the glass has closed off the blood vessels and it goes white. So that means it's not bleeding into the tissue spaces. But if you press on the rash and it doesn't blanch, that means that the rash is caused by blood in the tissues and therefore is a more serious clinical feature. Now, a hematoma just means a collection of blood where there shouldn't be one. So a hematoma, there's been bleeding in some internal area or indeed just under the skin, and the blood is collected, and over time the blood will coagulate, and that is a hematoma, a collection of blood where there should not be a collection of blood. Now, another type of hemorrhage is postpartum hemorrhage. Most of these occur immediately after delivery of a baby. And postpartum hemorrhage, globally, I think, is the most common cause of maternal death after delivery. Mums can simply bleed to death. For example, there could be retained placenta in the uterus, which leaks out lots of blood. And you have to remove that retained placenta and then get the uterus to contract down, probably by giving drugs to help that process. But then there can be other bleeds per vagina not associated with childbirth. Well, obviously menstruation is normal, but hemorrhagia is where there is an increased amount of blood. Not hemorrhagia, sorry, menorrhagia, that's the word I was looking for. Menorrhagia is where there's an increased amount of blood lost during the normal monthly periods. And that can give rise to anemia because quite large amounts of blood can be lost in menorrhagia. Fibroids, for example, are growths within the myometrium, resulting in increased surface area in the endometrium, resulting in increased amounts of blood loss in menorrhagia. And it's also worth pointing out here that bleeding in between periods is always abnormal, and bleeding after the menopause is going to be abnormal, and both of those should be explained. So it's quite normal to lose blood during the period, of course, during the menstrual period. If you lose too much blood, that's menorrhagia. But also if you bleed in between periods or you bleed after the menopause, that's abnormal, and again, that should be explained. Now, another important clinical observation is bleeding from gums. Now, this can be caused by periodontal disease and gingivitis, inflammation of the gums. But it can also be caused by various blood diseases, like lack of platelets. And it can also be a feature of more sinister blood diseases, such as leukemia or aplastic anemia. And it can occur also as a result of scurvy, if someone is very short of vitamin C. Now, bleeding can occur into joints. I've only seen this in haemophilia, but some haemophiliacs come in with very painful joints because they've bled into them. I think you might call that a hemoarthrosis, where you bleed into joints. And the last one I want to mention in this section is pulmonary edema. Now, in pulmonary edema, you can get bleeding into the alveoli from the capillaries, and by the time this gets to the surface, again, it's all very well mixed in with the mucus, and by the time the patient coughs it up, it's pink and frothy. So pink and frothy sputum is a sign of pulmonary edema, quite severe pulmonary edema, actually, if the patient is coughing up pink and frothy sputum. So let's just run through those briefly. Observations that we might make in disease processes relating to hemorrhage. Hemoptysis, the coughing. Hematuria in the urine. Hematemesis in the vomit. Melena, dark and tarry blood in the stools. PR, blood leaking out of the anus. Intracranial into the brain, subarachnoid into the subarachnoid space. Contusion just means a bruise. Purpura means areas of discoloration because blood has leaked under the skin. Petechial is small rashes which start off red and then go a dark colour. Hematoma is any collection of blood where there should not be one. Postpartum hemorrhage occurs after delivery of a baby. pervaginal bleeding. If there's too much, we call that Menorrhagia. It's also abnormal to bleed in between periods and after the menopause. Bleeding from gums, joint pain I've only seen in haemophiliacs, and pink frothy sputum in pulmonary edema. Now, in acute hemorrhage, someone can lose a lot of blood really quite quickly, and that can result in effects such as tachycardia, peripheral vasoconstriction, cold peripheries, even a drop in blood pressure. But in chronic hemorrhage, very often less blood is lost, but over a longer period of time. It's like a dribbling hemorrhage, if you like. The patient might be losing a little bit of blood every day, but it's enough to build up. Because if the patient's losing more blood than their bone marrow is making, then they're going to become progressively anemic. In anemia, there's a reduced amount of hemoglobin in the blood. And also, the way I define anemia is that anemia is a reduced oxygen carrying capacity of the blood. And that can have short-term effects and long-term effects. So the patient might start to look a little pale. When you test the blood, the hemoglobin's going to be low. And the symptoms are insidious. They tend to come on slowly and progressively. So the patient realises that maybe they don't feel quite as well this week as they did a few weeks ago. But it can take days, weeks, or even months for the patient to realise that they're getting ill. There's a general tiredness, because if there's not enough red cells, not enough hemoglobin, that means there's reduced amounts of oxygen going to the muscles, so the patient starts to feel tired. And there can be faintness and dizziness because of reduced amounts of blood being taken to the brain. And of course,